Dr. Naval Daver is an associate professor in the Department of Leukemia at MD Anderson Cancer Center. Dr. Daver is a clinical investigator with a focus on molecular and immune therapies in AML, myelodysplastic syndromes, and myelofibrosis. He is especially interested in developing monoclonal and bispecific antibodies, immune checkpoint, and vaccine-based approaches in AML, MDS, and myelofibrosis, and is leading a number of these trials at MD Anderson. He is the principal investigator in over 25 ongoing institutional, national, and international clinical trials in these diseases. Dr. Daver has published over 200 peer-reviewed manuscripts and has authored numerous abstracts at national and international conferences. Thank you so much for being here today with us, Dr. Daver. We really appreciate it.
All right. Yeah, thank you very much. And my pleasure. Do I share my screen or how do we?
Yes, if you could share your slides, that would be great.
Perfect. I will do that. And it was great listening to Dr. Oran's talk. A lot of progress happening in transplant. So let me see here. Get this to full screen. There we go. Okay. Do you see full screen now? Everything is looking good?
Yes, everything looks great.
Okay. So I'm going to be talking about emerging and novel agents. And I have to say right at the offset that this is a little bit of a difficult topic to kind of summarize to, patients and caregivers, just because a lot of these are very new drugs and that's great. And hopefully they will emerge in the future, but a number of them may or may not, right? So we're doing a lot of research. By far, we are the lead cancer research center, and especially for leukemia, we have a huge amount of trials, 2 to 3 times more than most other large academic centers, and a number of drugs that you've heard about already that have been approved actually were developed initially at MD Anderson over the last 3 to 4 decades. So there are a number of new pathways that I'm going to talk about. And I think the key from this talk, even before I give the data, is that always look for clinical trial options. Of course, ask your treating physician, ask your nurse, APP, but also look online. Sometimes, especially in community settings and smaller academics, even the physicians, because they see many different cancers, they may not be aware of the most cutting edge targeted therapies, immunotherapies out there, some of which could eventually lead to breakthroughs. But of course, it can take 3-4 years for them to move through FDA approvals, et cetera. And so it's important as a patient, caregiver, advocate, or organization to be able to pick these up early, because for that particular patient, that may make a huge difference being plugged in early on rather than 3-4 years later, because sometimes we don't have that much time in the setting of AML. So really focusing on clinical trials. Progress is happening very, very quickly in AML. And there may well be something already out there, even if it's in the very early phase 1, that one should look out for. These are research funding and consulting. I do a number of clinical trials, as was mentioned. And so we have a number of different sponsors, including external and internal and NIH, et cetera. So this is the slide I like to show because it really highlights the progress that's happening in acute myeloid leukemia. And it's very obvious, right, from a very quick view that we did not have as much success for about 40 years. And this was not due to lack of trying. The acute myeloid leukemia community has always been very, very hardworking, aggressive, innovative. It was just that AML, and we continue to see this is a very difficult disease. It's multiclonal. It's not one driver driven. The immune system itself is dysfunctional. Multiple mechanisms of resistance exist, as opposed to CML, ALL, where there's usually one clone, one mechanism of resistance. Immune system is not as perturbed. And so it took many years. But now in the last 4 or 5 years, we're seeing the culmination of research efforts over those last 3 decades, especially in the setting of genomic profiling and understanding the prognostic as well as the biological impact of various mutations. FLT3 being the most common one, IDH1 and 2 not as common, but important, especially therapeutically and biologically, and now more recently, even NPM1 MLL. And so we really have moved in the last 5 years to what we have talked about for decades, which is personalized therapy in AML, selecting the therapy based on the underlying mutation or particular immune antigen exposure. And I'm going to talk a little bit more about that. I'm sure you heard a lot of this already from Dr. Kadia and Short, but 9 drugs approved now. This is great. We're making progress, but still, I think the 5-year survival when we take all AML patients, even today in 2022, is probably going to be in the range of 35 to 40%. For younger patients, yes, it's getting better. We're getting close to 65, 70% in general, except for the really difficult ones like TP53 adverse cytogenetics. For older patients, we're starting to make progress with HMA-VEN and Venetoclax-based backbones, but we're still probably at 35, 40% long-term survival at best. So what can we do to move these bars even higher? We're doing better than a decade ago, but still we would like to be closer to 90, 100%, not 35, 40%, even for older and relapsed AML. So I'm going to first talk about what we have available today. Some of these are approved. Some of these have shown very clear data. They may not yet be fully FDA approved, but it's a matter of time. And I would urge patients and family to look for those targets if they have them in their leukemia. And if they do, bring it up to your provider and consider going on a trial with those targeted therapy approaches. So the ones that are established are FLT3. There are 2 FLT3 inhibitors already approved, gilteritinib in the salvage setting, but also being evaluated quite extensively in the frontline setting. Our experience is that it works very well in the frontline setting in combination with intensive chemo, as well as in combination with low-intensity therapies like Venetoclax. We are doing trials combining FLT3 inhibitors in the frontline setting in those settings. Moving away from the first generation midostaurin, which was a good drug, but is a weaker FLT3 inhibitor, older drug. Gilteritinib is more potent FLT3 inhibitor, more specifically designed, and a new generation drug. And eventually in the future, I think gilteritinib and also another drug called quizartinib are the 2 best FLT3 inhibitors that will be used more and more in the upfront setting. So again, if you have a newly diagnosed AML with a FLT3 mutation, consider discussing the options to go on frontline trials or frontline standard therapies with gilteritinib, quizartinib. We have preferred those over the standard midostaurin. I think in the next 1 or 2 years, the data will continue to show that with the rest of the academic community switching there. Transplant is key, as discussed by Dr. Oran, and again, very important to be seen by transplanters early on. Within the first week is really our goal. When we see a new AML patient below 77, 78, even today, we're pushing the transplant age up. We try to get transplant consult right away so that things can move in parallel while we're working to get remission. Transplant is getting financial clearance, transplant work up, and also donor identification, etc. IDH inhibitors, I'll talk a little bit about. There are 2 approved, enasidenib, ivosidenib. One of the key themes of my talk here is that the way the drugs are approved is not the optimal way to use them. And this sounds counterintuitive, but this is something we do every day, right? In fact, our chair, Dr. Kantarjan, who is considered the father of modern leukemia, has been here 40 years, many drugs approved under his name. He has more than 2,000 papers, says that in fact, the real research begins after drug is approved. And I think that statement is very true. When we look at all the drugs approved 8, 10 years ago, we're not using any of them the way they were approved. We're using them in novel combinations, MRD settings, maintenance, sequentially. And this is what we're starting to do with IDH inhibitors. That are single agents, they give you, yes, some limited benefit, but once you combine them with Venetoclax, with HMA-Venetoclax, with frontline intensive chemo, then that limited benefit becomes more pronounced and more curative. Now, the new targets that I think especially are more important even for those who may be having AML or relapse disease and are looking for options are the bottom 3, the NPM1, the TP53, and MLL. And for the NPM1 and the MLL, there is now a new group of drugs called Menin inhibitors. We think this is one of the next major breakthroughs. We have already seen data in close to 100 patients with different Menin inhibitors. We at Anderson are very fortunate. We have all 5 clinical trials with Menin inhibitors. 5 trials have already started, and all 5 of them, luckily, we are involved with. And we think this is a very clearly effective strategy to targeting relapsed MLL and NPM1. And MLL is especially important because people who have MLL-Rearranged or KMT2A AML, historically, that has been an aggressive subtype associated with lower response rates and shorter duration of responses to standard therapy. And so the Menin inhibitors showing very clear activity there, we think are very important. Now, again, with those, moving them upfront into combinations is going to be where we think they will have a further bang for the buck, literally in this case, because all these medications are expensive. So we want to use them where they really improve cure rates rather than just median survivals by a few months. But I think the Menin inhibitors are important. So look for those if you have MLL, NPM1, talk to your doctor. And the last one is TP53. This is the most difficult subset. I'll talk about it a little bit more. I don't know yet if we have clear breakthrough. We have signal with a couple of approaches that are showing some improvement in TP53. It's important to note some improvement. You know, we get a lot of patients who come to us, they hear about the drugs like CD47 APR, and they're hoping that these are curative. And unfortunately, that is not, we would love it to be, and we're going to work to that, and maybe we'll get there in a decade or so. But today, they are giving us improvement to what we have seen historically. That is still good. But I think with that improvement in responses, better tolerability, and then sequencing patients quickly to allogenic stem cell transplant with that total therapy continuum approach, then we can start making progress. And I'll show you some of that data. We work very closely with our transplanters in TP53 and FLT3 especially, because we have realized the earlier we can get patients to transplant with limited exposure to chemotherapy cycles without beating up patient and organ function too much is where we are actually seeing the best success. And then post-transplant, we can do additional strategies, maintenance, et cetera, to further improve the outcome. And so more and more, we're doing more transplants today in AML. And that is because we are getting better therapies with safer, easier remissions. And the transplant is the only true curative option that we have, especially for TP53, FLT3, where really without transplant, the outcomes are quite poor. So IDH1 and 2, I'm not going to go into too many details here, but this is the way these drugs were approved, right? And so I always, when I give these talks also to my academic colleagues and others, I say, you know, if you told a patient that, you know, this drug is great, fantastic, and he said, well, what's the median survival? I mean, it's like 9 to 10 months. Okay, well, that's good from a regulatory statistic perspective, because, you know, when you look at the outcome in patients who got standard chemo or other standard therapies, it's worse. The median survival is 6 to 7 months. Actually, our group, Dr. Donardo, Contardi and colleagues published this. So yes, 9, 10 months is good. Yes, it's very nice because it's an oral therapy. It can be given outpatient. And so, you know, it's a nice option for patients, but really that's not where we want to be a decade from now. We think this is a nice single agent, safe agent that can now be combined potentially to further improve those survival curves to hopefully curative outcomes. And we're starting to see that. So about 3 years after the single agent approval, now we have this randomized study, as Dr. Rand mentioned. Randomized means 1:1 comparison of azacitidine, standard therapy, frontline MDS AML for 3 decades, versus azacitidine plus the IDH inhibitor, ivosidenib, in newly diagnosed patients who are older than 75 years of age or not considered to be candidates for intensive chemo. This is about 60% of our patient population today, either older than 70, 75, or 60 to 70, 75 with comorbidities, kidney issue, severe hypertension, cardiac problems, where we are nervous to give intensive chemo. We know the mortality could be high, ICU stays, infection, sepsis. So we are looking for effective non-intensive approaches. So the primary endpoint here was event-free survival, but also co-primary key secondary of overall survival. And as you see here, we clearly saw that this combination now in the frontline setting is showing night and day difference. The response rate was 47% versus 15%, 3 times higher, not even double, 3 times higher. Overall response rates were close to 55, 60%. But really what was most important was this. I wouldn't worry about the event-free survival. This is something we debate for hours with the FDA on the way they look at event-free and we look at event-free. It's very tricky, but overall survival is overall survival. We all know that. And when you look at that survival curve, I think we're now starting to see kind of progress that we want. We're actually seeing median overall survival, going from 8, 9 months to 24 months. So not 20, 30% improvement, tripling of median overall survival. And more important to that, from a patient perspective, there are a number of patients at 2 years and beyond who are still alive and in remission, close to 45, 50% based on this curve. This should be updated in the next year or so. So again, you see that single agent IVO, yeah, it got you from 6, 7 month historical to 8, 9 month. Very nice. Okay, got it approved, meet statistics, but 2 to 3 month improvement. Clinically to a treating physician and to a patient, it's not something we will jump for joy. This, I'm getting more excited. We're talking about 2, 3 years into older unfit AML, who historically only 10, 15% would make it, even 2, 3 years. Now we have 45, 50% ongoing in remission. Most of these completely transfusion independent, getting labs once every 2, 3 weeks. And so again, combining it upfront shows a much better profile. Now, one could say, well, yes, but what about Venetoclax? And in fact, for some of you who have discussed or read some of the data, you know, Venetoclax does very well in the frontline AML, especially in the IDH mutated. So there's a big debate in the academic community. If I have a newly diagnosed 76-year-old IDH1, what should I do? Should I do Aza-Ivo that looks so good, 24 months, but you know, we have AZA-VEN, that looks pretty good, 18, 20 months, response rates are good. I don't have to wait for IDH. At Anderson, we say, I don't think you need to choose between these two doublets because neither of them appear curative. We're not seeing 90% alive at 3 years, where then we could have this debate about, oh, let's choose one of the doublets and maybe safety is being compromised if you combine. For now, we think that the way to go is combine these drugs in the optimal way and see if we can actually increase both survival curves, HMA-Venetoclax and HMA-Ivo, and start getting to 70, 80% long-term survival. In fact, some of the early data on this study done by Dr. DiNardo and Lakowitz from our group is starting to show scorching response rates, 80 to 100%. We have never seen this kind of response rates that with IDH inhibitors, whether alone or with AZA, and at 2 years, about 70, 80% patients seem to be alive. So I think just like we have learned in ALL, acute lymphoblastic leukemia, and multiple myeloma, where this is a very well-established theme, there's no debate that optimal combinations of drugs give you much better outcome than single agent or even doublet. This is where the field is going in AML. And again, I think something to think about, discuss with your treating physician, discussing with academic centers close to you where some of these studies may already be ongoing. Now, what about targeting MLL and NPM1? So this, I think, is very important because even though it's only about 10 to 15% of AML, this is a group for which, you know, just about 2.5 years ago, we had nothing. If you had a relapsed AML, yes, we would try many things, trials, intensive chemo, HMA-VEN, but 20% was really the rate of long-term remission we could achieve, even 15 to 20%. So now we have this group of targeted therapy developed after more than a decade of intensive preclinical lab work. A lot of this was done actually at Dana-Farber Sloan Kettering by Scott Armstrong and others. And now clinical trials are being run extensively across the United States, and especially for pediatric AML, as well as for ALL, acute lymphoblastic leukemia. There we can see the MLL-Rearrangement, which is also called KMT2A rearrangement rates, can be quite high, up to 50, 80%. So this drug and this target and pathway also has a very important role in pediatric ALL, which is why we're working very closely with our pediatric colleagues to bring this quickly to kids, where it may have as much or even more importance in the near future. The way these drugs work is not that critical. We don't need to go into detail, but they work through epigenetic modulation. This is a whole new area of science, not just in leukemia, but lymphoma, myeloma, solid tumors. And I think a number of drugs in the next 2 decades will be approved through epigenetics. So we went through the targeted therapy revolution where you find a target, you hit the target, you clear the disease, many drugs approved that way. Then we have the immunotherapy area, immune checkpoints, CAR T cells. Those are all now into reality where you use the immune system either internally activated to fight against the tumor, externally deliver potent T cells that fight against tumor. And now we have epigenetic and metabolomic. Those are much more complicated, but in fact, probably govern all of the immune and targeted approaches to some extent or the other, and a lot of research and cutting edge technologies going in, which has led to these kind of drugs, which actually reprogram the entire tumor environment and the metabolics of the tumor, allowing them to undergo differentiation. And this is, I think, an important concept. So normally what happens in AML is that you acquire a mutation or aberration, and then the cells get stuck in a premature primitive state and they do not mature normally. And over time, they multiply. You get a number of these primitive premature cells. These are called the blasts. I'm sure all of you have heard of those. They don't function normally. They don't protect against infection. They don't lead to red cell producing cells. They don't lead to platelet producing cells. And over time, they become the dominant population, pushing everything out of the bone marrow. So now these new drugs, both IDH inhibitors and the Menin inhibitors, what they do is they actually are able to epigenetically reprogram and remove that differentiation blockade. And so all of these primitive, immature, useless blasts to some extent that are occupying and destroying the bone marrow now start suddenly maturing into normal cells, neutrophils, monocytes, And those cells can then go and start doing their normal function, protect against infection, protect the mucosa, lead to normal platelet producing cells, etc. And so this is a very cool way where we're actually just reprogramming the tumor to behave like it should have behaved before, rather than killing the tumor. So much more physiological approach, and we're excited about that. Clinical data, a lot of this will be presented at ASH this year. Updates from at least 3 of the menin inhibitors are expected. The one that's most advanced and already in discussions and hopefully in the near future for approval is a drug called Syndax. Cura is another one that is close behind. And as you can see, the single agent drug, and these were 3rd and 4th relapse, are giving response rates close to 50%. That is quite phenomenal. So even with intensive chemo in a 3rd and 4th relapse, MLL-Rearranged, we have published the response rate is close to about 25%. Here with a single oral therapy, quite well tolerated, outpatient treatment, close to 50%. And again, like IDH, I think the real benefit is going to come when we move this upfront, combine it with HMA, Venetoclax, intensive chemo, and then the cure rates will start going up, as we saw with the AZA, ivosidenib, and those studies are already starting now with the menin inhibitor. As I mentioned, differentiation is the way they work. This can lead to a syndrome called differentiation syndrome, where sometimes you get too much of a good thing. So too many of the leukemia blasts overnight differentiate in neutrophils, and you get suddenly 10 times more neutrophils in circulation than you should have. This can cause problems, especially in the lungs, where the neutrophils like to go, inflammation, people could have some shortness of breath, fever, skin rashes, kidney issues. So something to think about. Your physicians will be quite familiar with this. We have done a lot of education, a lot of papers coming out from many groups about this, but that is one of the side effects. The good thing is a couple of days of steroids, differentiation syndrome shuts down 100% of the patients, and then you can continue with these drugs. But otherwise, actually very well tolerated. You don't see hair loss, no mucositis, no diarrhea, not much of a GI side effect, not much of skin changes. And that's true for all of these targeted therapies. They are very, very well tolerated in general, but there are specific side effects one should be aware of. Clinical trials. So as I mentioned, there are 5 of these. These are not just open at Anderson. The Syndax is open at about 30 centers across the US, Cura in a similar number. The others are starting to open up. So there's a very, very, very good chance that 1 or 2 of these menin inhibitors are open somewhere close to you within a 100-mile radius. You can check for these. Again, discuss with your treating physician. This may or may not be an option depending on what mutations you have, but there's no harm in asking and checking and making sure that this is not an option that is being missed. So last, the TP53 I'm going to talk about. I think this is the area where clinical trials are absolutely critical. I think 100% of TP53 mutated frontline patients should go on trial. Unfortunately, today in the US, we're probably somewhere at 10 to 15%. And part of that because we didn't have trials that showed any promise. Now we have them, so hopefully we can complete them. This benefits the patient. They get better therapy, or hopefully better therapy, benefits the trials, and benefits the future progress for other patients where we can know things are working, hopefully move forward. So AZA Venetoclax, lot of debate. You probably may have seen or heard of this, or maybe your doctor discussed with you. 2 years ago, we said, yeah, AZA Venetoclax looked like it gave some benefit in TP53. The response rate looked not too bad, 55, 60%. That's encouraging. We hope this will lead to a better outcome. Unfortunately, now 3 different subsets, 3 different studies have all shown that with HMA-Venetoclax backbone, the survival has not been improved in TP53 mutated AML. It remains very poor and similar to what you got with azacitidine decitabine. Now, again, these are medians. So does it mean we don't have any TP53 mutated AML who are alive? No, we do. We do have patients where we can get them into remission. We have worked closely with Dr. Oran and colleagues, got them to transplant, done maintenance, but unfortunately that is the minority. So we always will try, but we do know that the odds are unfortunately against us. And we've kind of moved away from using HMA-Venetoclax as the standard backbone or the only backbone for TP53. We may add novel drugs to it, or we may move to a completely new backbone, because this is the one subset where HMA-Venetoclax has not really shown a significant benefit. Everything else, it has shown some benefit. The benefit may be a little bit, or it may be a lot, but with TP53, we think really maybe not much benefit at all. So immunotherapy, right? And this is where we think in the future most of heme malignancy is going. I mean, in fact, ALL, diffuse large B-cell lymphoma and multiple myeloma are already there. If you hear talks from them, you will see 70 to 80% of the talk is about bispecific, CAR T-cell, immune checkpoint combinations, etc. We are not there yet in AML, but that's not surprising. We were about 10 years behind to get targeted therapies and molecular therapies after multiple myeloma. And I think immunotherapy also, it's going to take a little longer, again, because it's a more complicated disease, many different clones and a lot of immune aberrations that are already existing in AML, whereas lymphoma and ALL don't have that same problem. So this was a paper we published kind of reviewing all the immune targets, Dr. Short and me. And a lot of these, it's nice to see, have actually entered trial, and some of them have actually moved on to phase 3s, and we hope in the next year to potential drug approvals as well. So I'm going to talk about one that has generated a lot of interest, and we hope will be one of the steps to improve outcomes in TP53 mutated AML. This is a pathway called CD47. So of the new pathways, we're most excited about the Menin inhibitor. You heard about that, MLL-Rearranged patients, and then the second CD47. And this specifically in AML is being focused more in TP53. Now, it's not exclusively in TP53 where it works. In MDS, we're actually using it for all patients, but in AML, that's the area of most unmet need. And the way this works is kind of cool. It's an immune pathway, but it's not working on the traditional immune cells that you're used to thinking about or reading about when you say immunotherapy in cancer. Those are the T cells, and the checkpoints are PD-1, PD-L1, CTLA-4. So this was a whole new innate immune system pathway using macrophages, which normally come and phagocytize tumor, foreign antigens, viruses, kill them. But in the leukemia and lymphoma and solid tumor setting, the tumors actually are very smart. So just like they shut the T cells, they find ways to shut the macrophages through CD47 SIRP alpha, and they inhibit the macrophage activity. So by blocking that inhibitory interaction, we actually are unleashing the macrophages and they attack tumor cells. And in fact, combining them with azacitidine seems to further enhance that activity. And very nicely, Revumenib and the group at Stanford did a lot of preclinical work, very high impact, major preclinical papers showing that you can combine these two drugs and get very synergistic activity in the preclinical AML models. So then, of course, this has to be taken in clinical trials. So there are now a very large clinical program with this magrolimab, but there are 4 other CD47, but this is the most advanced. In TP53s, where we're focusing in AML, in the single arm studies, we're starting to see better response rates close to 50%, many of them with residual disease clearance. And the durability of responses seems much better than what we have seen with AZA alone, azacitidine, venetoclax alone, and in general has been very well tolerated. Now, that being said, one has to be aware of side effects like anemia. There has been a lot of discussion about this. This is really the only side effect we see. What's critical is that this anemia is very time limited. So when we looked at this across our patients, we saw that 99% of the anemia happens in that first 2 weeks. Very few patients will have it later. And so if you're getting on magrolimab or know somebody on it, the key is early monitoring of anemia. Be aware of that. That is a on-target activity from clearance of old red cells. But other than that, has been quite a generally well-tolerated drug. So again, kind of as we mentioned, the key here is to get transplant on board quickly. So you get the patient remission, you get them to transplant after 2 cycles, ideally maximum 3. And there is where we're now starting to see very encouraging survival, 2-year survivals going up to 60% or more, which in TP53 is fantastic. Now, as you can see, it's hard to get patients there. And that's where we're working very closely at MD Anderson with our transplant colleagues to see how we can move this from 10, 12% to 50% people getting transplant. And I think we are already getting better. So hopefully this data will continue to mature, especially with transplant following the HMA-CD47 and then maybe even maintenance afterwards. We also have studies for TP53 that we're getting a lot of patients coming to us combining the 3 drugs, azacitidine, venetoclax, magrolimab. This was shown at ASH. We will update it. The preclinical data suggests that there is synergy when you combine all 3 drugs. This was done by Marina Konopleva, who's one of the leading leukemia scientists in the United States. She was at MD Anderson. She's now at Albert Einstein in New York. But we think that the 3 drugs, due to some unique synergies between each of those doublets, may be the way to go. And so this is also ongoing. I mentioned anemia. And again, for all of you patients out there, this is not unique to Anderson. In fact, these studies are now open at close to 200 centers across the world, so not even just in the US. So there are 2 studies in frontline AML ongoing, one for TP53 mutated and one actually for all older unfit AML, regardless of mutation, to see if the 3 drugs could just improve on AZA-VEN alone. I think that's a very, very good study. I'm quite excited about that. If you have that study near you, I think I would consider it strongly, because you are getting the standard of care AZA-VEN anyways, and then you're getting the addition of the 3rd drug, which based on our ongoing data suggests it will improve outcome. And so this is the kind of study we like to do, where everybody gets standard of care plus versus standard of care. And of course, can you improve on standard of care is what we would like to see. So, these are ongoing. I'm going to skip. There are other approaches, targeted therapies, and immunotherapies. Again, as I mentioned, we don't have any clear breakthrough yet in cellular therapy, but compared to 5 years ago, when there were about 4 or 5 cellular therapy studies in AML, today there's more than 120. Usually progress meets hard work and innovation, and I think we're at that stage. My gut feeling is in the next few years, we will see cellular therapies come into AML. NK cells are the ones we are seeing very encouraging activity, especially in low burden, minimal residual disease setting. Dr. Short and Kadia discussed MRD is not just a marker. I think it's actually a setting where you can use particular therapies like immunotherapies at a better way than they would have been in bulk disease. And we're starting to do those. So consideration for immunotherapy trials in patients with relapsed AML, I think should be very high priority. We're getting better with the CAR T and NK approaches. We used to have to do autologous, where we connect it from the patient, then you have to process it, expand it, ship it back, takes 4 weeks. Now we have generated cell lines or umbilical cord blood, where we can produce hundreds of units of NK cells or CAR T cells, have them on the shelf in our pharmacy. And when we see a patient MRD positive, low burden, within a day, 2 days, we can proceed with the NK cell infusion. And this, I think, is the way to use them in the future. It is unrealistic to hope AML will stay stable 4 to 5 weeks. And that's what we are doing. A number of different modifications. I would look out for NK cell studies, especially for patients with low blast persistent disease that chemo or venetoclax sometimes cannot get rid of. This is where NK or bispecific antibodies or other immune approaches could come into play. I'm going to skip that. And I think this is the future treatment paradigm. I didn't talk about this much, but a lot of our research is moving in direction to minimize, if we can, intensive chemo. So using combinations of targeted therapies with venetoclax, with HMA, with antibodies upfront, debulking the disease, 99.5, 99.9%, you can get it down with these approaches, and then bringing in immunotherapies, CAR Ts, NK cells, bispecific, to mop up that remaining small residual disease. That's where the immune system can be used. The immune system cannot be used to get rid of 40 and 50% blasts. You have trillions of cells, but when you're in the millions or hundreds of millions, the immune system can overpower that remaining disease. And that is actually the exact paradigm that has worked in ALL, multiple myeloma, and lymphoma. So I think in AML, it's up to us to get there. And I think now we have the tools, the trials, and hopefully this will lead to more cures in the future. So I will stop over there. Thank you very much.